Good morning, everybody. Good morning. Thank you for being here. My name is James Simoes. We're here on behalf of Protect Our Care New Hampshire to talk about something that is really important to the future of our state, and that is the well-being and the wellness of our rural communities. Um, First, I want to welcome my panel of guests for this morning's discussion. The Healthcare Policy Coordinator from New Future, Sam Burgess. Thank you so much for joining us. It's nice to see you. Tess Kuning, who's the President and CEO of Bi-State Primary Care, which is not only across New Hampshire, but I believe Vermont as well, hence the name Bi-State.
Thank you.
And Ed Sanshala, who's back with us again. Thank you from Amanuset Community Health Services in the North Country, right? Who's able to give us a perspective, but hopefully there's no more snow up there today. Um,
I think we're good, James. I see blue sky.
It's about time, spring. So we're talking about a serious subject today. I mean, 47% of New Hampshire's population and 85% of the state itself is considered rural. So half of our people in the majority of the state, there are more than a dozen rural hospitals and clinics across our state. And up to now, Medicaid expansion has helped to keep our rural hospitals open and our communities healthier. It has been essential to rural healthcare, and more than half of rural hospitals in America today are already operating at a loss. And what we're going to look at cuts to Medicaid that could push New Hampshire hospitals to reduce services, to merge, or in some cases, shut down entirely. So we're going to talk to the panel about what will happen to residents who don't have nearby care, who would have to take longer trips for basic and emergency services. And we're going to talk about the result, which would be, I'm assuming, worse healthcare outcomes, higher system-wide costs for everybody, and a loss of critical local employers and investment. So that said, I'm going to put this out there. Whoever would like to answer this, feel free. Um, how does Medicaid directly support rural healthcare systems in our state today? And what would Medicaid cuts mean for rural hospitals and clinics who are already struggling with staffing shortages and financial pressures? Who'd like to answer that first two-part question?
I'd be happy to start. Can you hear me, Chime?
Yes, I do. Please go ahead.
Okay, great. Yeah. So I think it begs us to sort of step back to think about what Medicaid is. And it has both a favorable human impact and an economic impact in our rural communities if we have a strong Medicaid program. So Medicaid is the backbone of our healthcare system. It improves health for all ages and communities. It supports strong and healthy families. It supports rural America, keeps us working. And that Medicaid is a healthcare coverage. It's comprehensive coverage of hospital and specialist and primary care and prevention, lab and x-ray and pharmacy for those that are eligible for Medicaid reimbursement, which means that you probably have a low income. So thinking about how it directly supports rural healthcare is that it is both for the community, for the people that are on Medicaid, and for the providers as well. And so it provides a reimbursement to the providers that would otherwise not be there if we did not have Medicaid.
Thank you. Anybody else want to add?
I just want to drill down a little bit from Tessa's perspective and bring us into North Country. She's spot on. And if we think from moving across Route 25 from Plymouth to Woodsville to the north, we have 6 critical access hospitals, 3 federally qualified health centers. And those federally qualified health centers, Midstate has 2 sites, I have 5, COAS has 3 care delivery sites, in addition to our community mental health centers. So when we get to the North Country, there is already a scarcity in resources, and in part that is a driver. We play really nice and collaborate very well in caring for our friends, family, and neighbors. So the Medicaid would adversely affect clearly the ability to get into primary care. And when we don't get into primary care, people are gonna present at the emergency department. And it's really not the place to get your diabetes taken care of, or your congestive heart failure, or their well child visit. It's designed for emergencies, and it's a very important structure. So that puts them at risk of bad debt, and none of the healthcare systems in the North Country, they're very economically fragile. If you're on the positive side of the economics, it's a really, really good day. So I think that that would be a concern. Uh, and so when we have those Medicaid dollars, the economic multiplier is 3 to 1, and those monies then move around within the local economy. People pay their mortgage, they buy groceries, they buy a car. So there is the human aspect clearly that Tess talks about, and then there's the economic impact of moving those dollars within our communities to keep them vibrant and growing.
And sorry, John, if you don't mind me jumping in for a quick second here, I want to join in on what Tess and Ed were discussing here a little bit, talk about what's on the chopping block right now in our state legislature. So Tess mentioned Medicaid reimbursement rates. There's currently a proposal to cut Medicaid reimbursement rate for providers by 3% across the board. That's going to have a huge impact, not only to Medicaid providers across the state, big cities, but it's going to have a disproportionate impact on rural communities whose economic fragility, as Ed mentioned, is all the more pronounced when it comes to Medicaid. I also mentioned too, not only is Medicaid a economic lifeline for rural communities, we have current efforts of the state legislature which are facing repeal. We have the student loan repayment program, which seeks to reimburse student loans for our healthcare providers who seek to work in underserved areas of the state. That's currently been zeroed out in the state budget that just passed the House. And I believe, I think we're also, as a state in here in New Hampshire, competing for healthcare professionals. We need these types of programs to ensure that we recruit and retain the healthcare workforce that's going to support our rural communities.
James, can I localize on the
Please, no, please. This
state
is a
loan
discussion.
repayment
Hop right in.
program? I smile when I see what I call local kids gone done good. And I have 3 advanced practice registered nurses, one of whom went to school with my son, went off to nursing school, became an APRN, and they work with us. And so it's great. We're part of the pipeline. Bi-State's been exceptional in helping us do that. North Country Health Consortium with their Area Health Education Consortium. People have worked really hard together, the state Department of Health and Human Services, so we can bring these students back after a lot of investing. Sometimes we see these kids starting in 6th grade at a healthcare camp, right? And that student loan repayment allows them to stick like burdocks to a wool sweater. And without that, it's hard for us to compete economically. They want to come back. They want to care for their friends, family, and neighbors who nurtured them as they grew up and came of age. But without that investment of the state loan repayment program, it's difficult. Typically, an APRN is 1 to 2 years. Sometimes recruiting a physician is 2 years, 3 years, 4 years. Very challenging. So those monies as an investment are essential for us to recruit, whether into the North Country.
I wanted to, thanks Ed and Sam. I wanted to just add on a little bit more about the effect that may happen in Congress and then the effect that may happen here in New Hampshire. So the right now the Medicaid expansion, which began in 2014, provides care for 60,000 Medicaid beneficiaries in New Hampshire. And there was a law passed when this Medicaid expansion that the anticipation that the federal government would provide 90% of the funding for Medicaid expansion beneficiaries, and the state would provide 10%. And that if that FMAP ever changed, that the state then would sunset the Medicaid expansion in 180 days. So that is something that if Congress makes changes to Medicaid, makes changes to the federal percentage that the state is paying, then we could be seeing 60,000 people sunset their coverage, their healthcare coverage. The other impact of this is that the state is about a $16 billion budget, and 2.5 billion of that is Medicaid, of which 1.5 billion comes from the federal government. So it's a really important economic driver for New Hampshire as well. So we talk about sort of the human impact, but also wanted to mention about the economic impact. So the way that Congress is at least the budget that was passed, the budget resolution, both in the Senate and in the House this last week, was that they're looking for $1.5 trillion of savings over 10 years and 880 billion over 10 years. So that's 88 billion a year in the committee that has jurisdiction over Medicaid. So what we don't want to see is a federal change to the FMAP that would cause an incredible economic burden to the state and a loss of that coverage. We also don't want to see the mandated work requirements as well. And we do have experience with work requirements back in 2018, where there was a work requirement that started in New Hampshire, and that we lost 17,000 beneficiaries in 2 months' time because of their inability to be able to do the redetermination. So thinking through about what a work requirement would be, what it would cause to the disenrollment of our Medicaid beneficiaries, and then, of course, what would that mean economically? So I just wanted to mention that there's sort of two ways in which Medicaid can change at the state level through either, as Sam mentioned, the decrease in the Medicaid reimbursement and also some of the programs like the state loan repayment, as well as a work requirement and the anticipation that you would pay a copay. And I just wanted to say one last word about the copay, which is, in order to be eligible for Medicaid, the way that your eligibility is tested is 138% of poverty. But what that means is somebody making less than $21,000 a year. And so this is incredibly important to families and to patients who are getting Medicaid because they're making less than $21,000 a year. And if you think about that's $1,800 a month. That's $1,300 for rent. And if you think about the energy costs, the rent costs, the food and housing, it's really an impossibility to be able to expect somebody making $21,000 a year to be able to buy health insurance. And most of the people on Medicaid are working, but they're not working in jobs that have employer-sponsored health insurance. They're usually working in industries that don't provide health insurance. So the importance of having a healthy community and having healthy workers benefits all of us.
If I take Tessa's perspectives and thoughts and localize them again, when we look at Amanuensis, it's 26,000 towns and 31,000 residents. We see running 3, just to contextualize it for you. That adverse impact on the human side is 485 humans. The economic impact for us having an $11 million annual budget, that's a $2 million decrease in investment in our friends, family, neighbors' health over the course of 3 years. And as Tess indicated, when we get to the North Country, we see small entrepreneurs, might be where I stop and get my cup of coffee, and they may qualify for Medicaid. And when we look at the housing market up here, trying to find something at $1,000 a month is very difficult if you can find it at all. The rental vacancy is 0.6%. And that dearth of access increases the cost of being able to find housing. And then when we look at the economy, I call it the gig economy. You're making snow on Cannon Mountain. You're a landscaper in the summertime. Maybe you're a waiter, you're a waitress. Your patchwork quilt of employment does not come with health insurance. Yet the local businesses expect that they can count on you to come and wait on a table, to teach a child to ski, to come and landscape, and to do that you need to be healthy. So I think that we need to think a bigger, broader, more systematic picture of these dollars. The 10 cents is our state money. That's mine and yours. And the 90 cents from the federal, that's our money too. We're bringing our state and federal tax dollars back into the state to invest in our friends and family, neighbor health. And they drive the economy. I think we need a bigger, broader view of what we have and strategically think about these dollars as an investment. Now we can talk about return on investment. My father taught me you can't cut your way to prosperity. At some point in time, you end at zero. So we need to think about this, I think, from a term of an investment, both on the human and the economic side.
I think it's a great comment. Sorry, I want to throw one more in. I know we'll probably want to move on at this point. I think Ed and Tess, you brought up amazing points. I do want to hammer home one quick point in terms of the urgency at this moment. And that's in regard to, as Ed and Tess talked about, the trigger law, right? The 9010 FMAP trigger law. So as Tess was mentioning, the timelines a little bit. So on the federal side, they're going through the budget reconciliation process. They have until approximately September to figure out where they're going to make those cuts. As Tess mentioned, it's all but certain it's going to be $880 billion, I apologize, aimed at most likely Medicaid. The biggest urgency we have right now with the trigger law is we in the state of New Hampshire with the citizen legislature have a 6-month legislative session, right? So there are legislators in our legislature right now trying to have that conversation that what is going to happen if our contributions from the federal level fall below 90%. Those conversations are currently being suppressed in the legislature. So I think we need to make this an urgent topic to say that, if let's say the federal government drops that 90% threshold down in July, right? Then we're heading into the off season with our legislature. There's no guarantee the legislature is going to convene for an emergency session. That's why we need to be having these conversations now to force the issue and to hold the legislature's feet to the fire to ensure that we have protections to save Medicaid expansion.
Yeah, thanks, Sam. I'm just going to riff off of that for a second, just to mention that any business, and the state of New Hampshire is a huge business, right? Any business does scenario planning. So what if? What if the economy goes in a certain way? What if the tax revenue isn't coming in? What if this is how we all, as by state as a business, as Ed at Amanuensis as a business, we all are doing scenario planning. So I think it doesn't behoove us to be able to sort of suppress a conversation. It's really important to have those conversations, and then it demonstrates really what the value of Medicaid is and why it's so important to our members of Congress and to our legislators to be able to understand what that means. And so I think sometimes Medicaid gets sort of in the swirl of, that's for the poor people, right? But it is for low income. It's for people that you mentioned are veterans. It's people that are elderly. Many of the people on Medicaid, or Medicare, rather, the low income folks that are on Medicare, use Medicaid as a supplement to their Medicare. We have not only, moms and kids on Medicaid, but we have rural Americans. We have people that are have a severe disability. The significance of the funding coming into the state for the not only for the community health centers, they are seeing 90,000 people across this state, and they're seeing about almost 20,000 elders. But you also have your hospitals that rely on Medicaid. You also have your nursing homes who rely on Medicaid. Your behavioral health, our mental health centers that rely on Medicaid. It is ubiquitous in our in the provider community in terms of a payer who pays for the services that are so important to people in order to make them healthy. Again, the purpose of Medicaid is to make people healthy. This is the whole purpose. It's not to do a work requirement. And as I mentioned, we've had already 3 examples of work requirements that have happened nationally in Arkansas and in Georgia and in New Hampshire. And New Hampshire made this commitment that there weren't going to be Arkansas. And what we found was that the way that you get redetermined and the process by which that happens isn't something sometimes agreeable to somebody who's working in the ag community or working in the service industry. So that is so important to understand what would happen. And I have to say that we have not seen any bill text at all yet. To Sam's point, we're at a place that they've put targets in with regard to what they anticipate will happen. But we did have last year we had a law, or not a law, rather, a bill that went through the House, and what it did was it did a redetermination on either a monthly basis or a quarterly basis, and that if you weren't redetermined, that there would be this clawback to the Senate, to the state, on monies that may have already been contributed to the managed care plans or to the provider community. So I think we have to be really careful about what does the bill text going to look like once they drop it, so that we can understand better what that actual impact is going to be to New Hampshire.
Thank you, Tess. And thank you also for hitting on the impact on seniors in the North Country. It was something I was going to ask about. We have the second fastest aging population in America after Maine. And just quickly, I'd like to ask, the panel to, seniors, veterans, we're seeing cuts to the VA. There's a large VA in the Upper Valley where many veterans rely on to get their care. And finally, also the impact that these cuts that are proposed would have on maternity care. We've seen a maternity desert form throughout central and parts of northern New Hampshire. Um, what are we looking at in terms of, prospective moms, veterans, and seniors? What's your take?
So if we look at, again, if we work our way from Route 25 from Plymouth to Woodsville and work our way north, we have Spear, they deliver babies.
They do.
I've been here since 2005, and during that time period, Cottage did. Now they do not deliver babies in Woodsville. Littleton Regional does in Littleton. Weeks in Lancaster stopped at about 2006 and 7. Androscoggin does, Colebrook doesn't. So that gives you kind of the sense of that landscape. And then we have the federally qualified health centers in there that work with the prenatal community, work with seeing moms, work with seeing the babies with the hospitals. So when we think about economic development, people want to know, a couple things they want to know. Where am I going to birth my baby? That's a fair question. Tell me about the schools. So I think that's really hard. And so it's doubly hard when I'm trying to recruit a provider who may want to have a child. I'm like, hey, I'm really sorry about, you're going to have to drive 60 miles to deliver your child. That's difficult. And then if we look at the schools, we have an aged population. 40% of our patients are Medicareable. They're on fixed income. We have a regressive property-based investment into schools. So these individuals who are on Medicare, could be Medicaid on a fixed income, struggle when they go to town board meetings to figure out what to fund the school. I love children, but I'm sorry, kids, I don't have any money. And then so to reduce Medicaid will actually ripple back into the schools. And then with our veterans, we have over 160 veterans that we provide care in and above what the VA does. And some of those individuals are on Medicaid as well, and so they will be adversely affected. It really is whether you like pickup sticks or you like Jenga, you have to be very, very careful in thinking systems that if I decrease this investment in this area, there's a direct impact, and then you got to follow that money through the system and see where else is that impact. And in some instances, it loops back around and hits the Medicaid patient twice or 3 times. So that's difficult. And then we have our nursing homes and our mental health centers. And their margins are in that 1-2%. So you take 3% away, you immediately throw them right into the red. So it is a very systems looking. I'm not sure who's thinking systems in the House or the Senate. I think it's important to do that from an economic perspective as well as a human perspective.
Yeah, I would just add about New Hampshire being a place where young families want to come and live and grow and set up their lives. And so it's really difficult as an employer to help a new couple coming into any place above Plymouth in terms of the North Country to think about, well, what would that mean for us? To Ed's point, looking at, okay, where is my primary care? Where's my hospital and specialty and tertiary care going to come from? Where are my kids going to go to school? And if I want to start a family, what does that mean? And so I think that's really important. There is such a connectivity, almost like this connective tissue, where families are thinking about what that economic investment would be for them and how valuable Medicaid is to our healthcare system. As I said, it is really the backbone. It's the backbone of the community health centers. That nationally, about 80% of the revenue for community health centers nationally comes from Medicaid because it's a highly, highly sought after, community health centers are highly sought after from Medicaid beneficiaries. In New Hampshire, it's a little bit less. We have more of our community health centers that are also seeing elders, so their Medicare population as well. But I think that, thinking about really the value of this, the peace of mind that people have to make sure that they have this kind of coverage and keep people healthy and productive, it's this no different than what would happen if I would lose my insurance, right? I mean, we seem to think that Medicaid is for sort of for those poor people, and yet those are folks who are neighbors, and they're people as Ed mentioned, they're in the service industry. They're people that are caring for and taking care of elders. They're taking care of their own family. So there are an incredible amount of support that we should be giving. We should all be protecting Medicaid. This is not just for this group here. This is for the entire state to say this is a really important benefit that comes to the state. The state and the federal government share in this. It's operated by the state. And so it's really important that people understand that it's more than just healthcare coverage for people who are low income. It is an economic driver in New Hampshire, and we cannot let that fade away in the conversations about the value of Medicaid. We shouldn't be having people feel that they're a burden on the system. And just the opposite. They're actually working. They're working in really important service industries. We are a service industry state, and we need people on Medicaid in order to make sure that they're healthy and they can come to work and that their kids can go to school.
Tess mentioned about the schools, and I want to take you back to 2018. We were in the top two states with West Virginia and opioid mortality and morbidity. And at that point in time, I made a strategic decision to move upstream to figure out why kids are falling into this. And so we put behavioral health into K through 12 schools to get ahead of those adverse childhood events, get the care they need. So when they become teenagers, there's decreased self-harm, self-medication. And a significant portion of those kids are Medicaid. Parent doesn't take off work. It doesn't fall in the school budget. The kids in and out of behavioral health care, just like a trombone lesson or talking to the soccer coach. So it destigmatized behavioral health in the school, normalizes it. And we're seeing a shift in the state to a healthier state and a decrease in substance use disorder, mortality, and morbidity, which is a return on the investment of Medicaid dollars. So if I go to my financial consultant and said, hey, I'd like to decrease my investments, that's an awkward thing to consider, especially with the types of returns we're getting. So it's just an example of a space where these Medicaid dollars are being invested, these kids in their out years decrease self-medication, decrease self-harm. They will graduate, they'll go into the trades, they'll open a business, they'll go to college, and they'll come back. So again, it's that long view.
Mm. Can I just mention one thing? Thanks for sort of bringing up this whole idea of opioid use disorder. And so when we brought Medicaid expansion to New Hampshire, traditional Medicaid did not have the benefit of medication-assisted treatment or opioid use disorder. And so because it came as part of the Medicaid expansion, there was parity with now. So they brought that service, if you will, the Medicaid-assisted treatment and opioid use disorder, to the traditional Medicaid as well. And we have nearly 10,000 granted staters that are covered by Medicaid that are receiving medication-assisted treatment for opioid use disorder. And New Hampshire has been a national leader in enrolling and using Medicaid recipients with opioid use disorder using evidence-based treatment. And so in 2022, 82% of Medicaid enrollees in New Hampshire with opioid use disorder were receiving medication-assisted treatment. That's the second highest rate in the country. So it is a smaller, of course, of the 182,000, 10,000 people, but that is a really important benefit that people will have in terms of being able to treat their addiction. And what we do know about people that treat their addiction is that they then, once they are treated, they are back into the work cycle. So it's a smaller population, but it's a really important population, and that we're leading in this. We should not take that benefit away.
And we're saving lives. I think that's an important way to wrap it
Exactly.
up. I mean, not only are we helping people, we're keeping people alive, and we've seen the overdose death rate go down. I just wanted to quickly say that we're pushing up on 10:30, which is great. This has been an amazing discussion, and I've learned a lot. I want to ask my colleague Rachel just to hop in before we go to final thoughts to see if any of, and we've got a nice group of media joining to listen in, and if any of them have questions for the panel that we could discuss.
Of course. Thank you, Jaime, and thank you everyone for joining us today and participating in this really wonderful conversation. If you are joining us with the press today and have any questions for our panelists, I please ask you can put those in the Q&A box at the bottom of your screen. And if you have a question for a particular speaker, you can note that in your question. Otherwise, we will keep it open to everyone here. Now, just to start off, we already have a great question in our Q&A box from Melanie Plenda. That question is, many of the Medicaid recipients are already working. Can you explain a little bit more about why the work requirement is not a good policy?
Sam, do you want to take that, or do you want me to take that?
Sure, I can take the broad view, Tess, and you can fill in the details with your expertise. Yeah, so work requirements, as Tess mentioned before, have been proven time and time again to be ineffective. I believe currently, as it stands right now, Georgia is the only state with active Medicaid expansion work requirements. And if you just look at the numbers, I believe I have them right here. Suffice it to say, they spent millions upon millions of dollars trying to administer these programs, not to actually provide services to the people they need in their coverage gap in their state, simply to administer the program and to essentially check up on those within the program. It's been an incredibly costly, expensive program to administer. And more than that, the effect, whether intended or not, has been to disenroll tens of thousands of people in these states. So it's been a very expensive program, and it's been an ineffective program, unless the intended effect is to disenroll people from the program, which has been very effective in doing.
Yeah, thanks, Sam. So yeah, I do the federal work for by state. Christine Stoddard does the front-facing work in the State House. And so I'm quite familiar working with my colleagues across the nation about what happened in Arkansas when they went to a work requirement, which meant that 95% of people in Arkansas were already working, and they disenrolled 18,000 people in 6 months. And so I think, Sam, you were talking also about Georgia. It cost $87 million to implement. They enrolled 6,500 people over an 18-month period, and there were 250,000 that were eligible for it. So we do not want to make the same mistake that we did before. And I think I get back to the premise of what is Medicaid, and the work requirement is really, it's an untested and unsupported premise of thinking that Medicaid, which is there to make people healthy, that we would require a work requirement when we know that so many people are already working. So it would be an administrative burden, and I'm sure Ed could talk about what that challenge would be for a person who doesn't have a computer, doesn't have connectivity, and maybe doesn't even know they're on Medicaid. So we have 3 managed care companies, and if I'm on Medicaid, I have a card that says WellSense or AmeriHealth Caritas or Centene, New Hampshire Healthy Families. I may not know I'm on Medicaid because I'm getting incredible comprehensive services through this insurer, right? So I think there's a piece here that we need to make sure that that beneficiaries know that they're on Medicaid, so they can also use their voice to say how devastating this would be for them to lose their benefit.
Yeah, to Tessa's point, I just did a quick math, and $87 million will get you over 200,000 primary care visits at a federally qualified health center. So where do you want to invest your money? And I'm always cautious about rules around the variance when we have policies and laws about the small probability, small n value. It tends to be very expensive to prevent something that wasn't going to happen anyways. So when I look at the challenges, let me just give you an example of when we look at our no-shows, which are actually really good. I ran into a question about a no-show of how do we get better. And imagine that you have an appointment scheduled with us, which does happen, and the restaurant calls you up and you get called in, part of the gig economy, to do lunch today, lunch to dinner, but your appointment was 3 in the afternoon. That's a no-show or a no-call. But you have a really bad choice. You can either not get called again for work, that hurts you economically, or you're going to miss a visit. So we try to figure out how do we accommodate patients like that, because we do want them to get their care. And we realize that sometimes they get called out at the last minute. You know, somebody got sick, they called off, they need to serve tables. And if they don't show, they won't get called again. So that gives you a snapshot into some of the challenges these people may have, because they're trying to balance their life in an economically challenging area. You know, so the work requirement just seems like not a place that I, as a taxpayer, want to invest $87 million into trying to play gotcha when there isn't anybody to find for gotcha.
And we have two more questions. Rachel, if you want to.
Thank you, Jaime. Yes, our next question is from Paul Kuno Booth from NHPR. His question is there any concern about the proposal to cut the state's family planning program, and how will that impact the North Country in particular? He understands the Coos County Family Health is one of the health centers that could lose funding if the program ends.
And we mean
Yeah,
COAS.
so,
Oh,
cost.
Okay.
It's okay.
Okay.
It's all right. I made the same mistake, and I asked if you could put the umlaut off the second O, I will pronounce it properly. So it's so I don't work for Quas Family Health Service, so I'm a little reticent to talk on behalf of Ken Gordon. I encourage you to reach out to him. What I can tell you generally is that will decrease access for women's health care well beyond obstetrics. You know, so that it is a very important when we look at HPV vaccines. That's within that framework. That is the only that I know of preventive cancer vaccine that we have right now. So it's a very important vaccine to prevent cervical cancer. So it will decrease access to people, and that is a significant investment in Coos County's family planning. And it does, he's it. That's the entirety of Coos County for a lot of people. You know, so it will have an adverse impact on him. I would encourage you to reach out to Ken, and he can give you more specifics on that. But that's basically from Berlin all the way to the Canadian border. A little bit of Lancaster, people from Lancaster may go see him as well.
Yeah, hi. Thank you, Ed. I'll just make mention, Paul, that the Title X funding that comes to the state of New Hampshire distributed through the family planning. So there are a lot of grants and contracts that are under threat federally coming into the state, and then the state operationalizing them into service, like the community health centers. But family planning seems to have this sort of lightning rod effect of that people immediately think about abortion. And I just want to bring people back to thinking about family planning as exactly what that is. It is thinking about the decisions that individuals and couples make with regard to their own family planning, making decisions about the number of children they have, the timing, the spacing of their children. It also is preventive care. So it's not just that piece of it, but it's also all the reproductive health and pregnancy, healthy pregnancy, the importance of perinatal care, making sure that people are healthy coming into a pregnancy, stay healthy during a pregnancy, and then the post pregnancy phase is all part of family planning. And so when you take this idea of something that's so important in terms of reproductive health, and then think about it in a really narrow view with regard to abortion, I think we're losing sight of the value of what family planning actually does and contributes to our state.
Thank you, Tess and Ed, for answering that question. We have one more question, and I think it kind of, builds off what you were just discussing. This is from Elijah De Castro. And could you speak a little bit more? How specifically would further cutting Medicaid affect maternity care in New Hampshire?
I mean, it'll adversely affect those who do the primary preventive care, um, in some degree for sure. I think my bigger concern is when I look at the hospitals. Like I said, we have 6 hospitals, and 3 of them deliver babies. So you can deliver a baby in Plymouth, but not in Woodsville, in Littleton, but not in Lancaster, in Berlin, and not in Colebrook. That already is a strain on the community for when people want to come to a community, regardless of payer, but especially for Medicaid. And if you're starting a new business, I know some new businesses that healthcare is a concern for them, and they're starting to stand up a new business, and high probability based on their income, they're going to qualify for Medicaid. So I think that is a concern writ large. To the degree to which it adversely affects the primary prenatal care through delivery, and the delivery is less than optimal, in part as a result of a lack of investment, decreasing access, then we're into NICUs. I don't know the precise data on NICUs. What I can tell you, though, is an ICU day in New Hampshire based on Kaiser State Health Stats is a $10,000 adventure nobody asked for. And the average stay for NICU kids are in days and weeks, sometimes months. So you can either invest on the front end, which I would encourage you to do, or you can spend money on the tail end for a probability that things may not work out well. And so they may not work out well, and it's expensive. I don't think anybody wants to invest in something that doesn't work out well, and it's expensive. It's just tragic on so many levels. So if I can't appeal to your sense of humanity, maybe I can appeal to your sense of, Chicago School of Economics, and we can talk about Hayek and Friedman in a different podcast. But so yeah, it will have an impact.
Yeah, thanks, Ed. Let me could just add, I think sometimes in these questions, it's really good to kind of unpack what that means. And what does maternity care mean in terms of primary care and prevention? It's all the prenatal care. So it's your regular checkups with your provider, making sure that you're monitoring the mom's health and the baby's health and providing education and getting somebody ready to birth. So going into the labor and delivery, assisting the labor and delivery, what sort of a birth do you want? Do you want a home birth? Do you want a hospital birth? What might that mean? What does a safe birth mean? And then, of course, your postpartum care, which is the follow-up with the mom and the child to make sure that they're both physically and emotionally healthy, and that the mother has recovered from the pregnancy. And then, of course, the newborn care, which puts you into all of the child care, right? So newborns, making sure that, at least making sure that they have their vaccinations and their breastfeeding or bottle feeding, and are they gaining weight, and all of those things. So I think the value of maternity care lies squarely in primary care and prevention, and then you toggle into where that birth will be and whether or not you even have an option of a birth in the North Country.
Thank you, Tess and Ed. I want to jump in really quickly here and talk a little bigger picture as well. So in the last 20 years, New Hampshire has closed, I believe it's 11 maternity wards. We currently have 15 maternity wards remaining and 3 that are freestanding in New Hampshire. So the direction has been going one way in terms of our maternity services. Most recently in 2023, I believe we closed Frisbee Memorial And we also had a freestanding birth clinic here in Concord close in 2023. That leads me to, I also want to talk from a systems level. When we have these large cuts to these health systems, there's a number of options of where these hospitals and providers can go. They could shutter their doors. They could shutter certain services, like we saw at Frisbee Memorial. We could also see what we've seen with the ongoing trend of consolidation, right? We see vertical consolidation, we see horizontal consolidation. And I think that's an important part of the conversation we're generally now, as well as making sure that patients in New Hampshire understand the deal that they're making when they get these consolidations in the state. I think HCA Incorporated is currently bought up 4 hospitals in New Hampshire in the last few years. They now have Frisbee Memorial in Rochester, Parkland Medical in Derry, Portsmouth Regional, and I think and now CMC in Manchester. There's a number of good and bad things you can debate on this. It keeps doors open in some places like our rural communities, which is a net positive. But there's certainly some negatives that come with that as well. One thing off the top of my head is bargaining power, right? Our state health plans rely on the bargaining power. When you have the largest health system in the country snapping up hospitals across the state, certainly that relative bargaining position is weakened. So I think ensuring that patients are aware of the deal they're striking with these consolidations is an important part of the conversation.
I want to make one more comment about the if somebody doesn't get Medicaid, right? If they're disenrolled from Medicaid, they are still the patients of the community health centers. They are still the patients of the mental health centers. They are still the patients of the rural hospitals. And so their care still needs to be provided. And community health centers are the only provider entity that has a requirement to see anybody regardless of their ability to pay. So you have Medicaid, a family that is on Medicaid coming into Ammonoosuc and they're disenrolled. Ammonoosuc still cares for that family. And so to this economic point, I know the community health centers alone have spent $15 million last year in uncompensated care. And that's care that should be for either uninsured or underinsured persons, shouldn't be the burden of the community health center. We should be thinking about this as a state to say, how do we keep our health systems healthy and how do we keep our families healthy?
Right.
Thank you
And to
all.
Tessa's point on the
Go ahead.
Medicaid expansion,
Final thought from Ed.
on the Medicaid expansion, I mean, we'll continue to see that the people, our base grant funding has been economically static for a decade against an economy that moves forward, where the workforce is challenging to find on a good day, and the uncompensated care for us, if Medicaid expansion goes away, is a $500,000 economic adverse impact against an $11 million budget. So I think Tess is right. We really need to think systems. So I appreciate Sam and Tess's colleagues because they're system thinkers.
Thank you. Those are all the questions we have time for today, and thanks everyone for answering these so fully. Jima, we'll turn it back to you.
Well, on behalf of Protect Our Care New Hampshire, and I think the state in general, I want to thank Tess, Ed, and Sam for really digging into these issues and giving us cautionary flags about what could happen if we don't make smarter decisions, but also talking about productive ways to move forward to safeguard the health of our neighbors, of our rural communities, and all of us in the state. It should be, in my mind, top of the list in terms of discussions of how we spend our money and not at the bottom. So thank you for forwarding that discussion and for the good work that all 3 of you do every day through your organizations to further the dialogue for good access, good healthcare, and stronger and safer communities. I thank you all, and on behalf of Protect Our Care New Hampshire, we're making a difference, and I really appreciate your time. Be well.
Yeah, thank you, Jime. Nice to
Jime.
see you, Ed and Sam. Thank you. Thank you,
so much.
Rachel.
Have a great day.